I I really want to thank Howard Gleckman, who's an expert on many things aging, for being here with us tonight. Howard, you've written about the impact of the Trump administration's policies on older adults and their families. Could you share what you see as some of the most critical, current, and emerging threats to their well-being?
Which side do I have? So you all hear about the fire hose, and it really is when it comes to programs for older adults, fire hose. There's Social Security. President Trump isn't going to cut benefits, but he's making it a lot harder to take the benefits. I worry a lot about Medicaid, which is the program that provides long-term care services, both at home and in nursing facilities, for low-income older adults. There are a number of proposals out there that we can talk about in more detail that can have really catastrophic effects on older adults. Think about Medicaid as an older adult program. And then there is a program that nobody's ever heard of, but very important, called the Older Americans Act, which is the law that funds programs like Meals on Wheels and elder abuse prevention, falls prevention, transportation, adult day, information referral. All of those kinds of programs are funded through this very obscure law, and they're managed in the Department of Health and Human Services, where they were 2 days ago, by a relatively small office called the Administration for Community Building, which did some very interesting things over the last 13 years since it was created by combining services for older adults and for younger people. And it became a voice for programs in the sprawling Department of Health and Services. President Trump abolished that agency last week and said he was going to spread the work that it does among 3 other offices at HHS. And then this week announced he was cutting staff in half. So there were questions about whether or not it's going to be his job and whether it's going to be administer Older Americans Act programs the way they should be. So those are just some of the programs that for Medicare we could talk about as well. Medicare doesn't provide long-term care, but of course provides health care for older adults. President Trump says he's not going to touch Medicare. I take that to mean he's not going to directly reduce benefits for older adults, but I think he is going to make some perhaps significant changes in the way we pay providers, and those changes could restrict access to Medicare programs. So there's a lot.
That's a lot. Maybe to follow up just a little bit about that. Medicare provides a lot of different benefits for older adults, and there are also associated programs with that. I'm wondering if you could talk a little bit about the importance of the SHIP program for Medicare access.
Sure. So Medicare, just to clarify this because everybody's always confused, Medicaid pays for long-term care. Medicare does not pay for long-term care most of the time. There are a few narrow exceptions, but for the most part, Medicare doesn't pay for long-term care. What it does do, of course, is it pays for health care. Medicare is unbelievably complicated for those of you who have applied. You know, there's Medicare Part A, and there's Part B, and there's Part D, and there's Part C, and then you buy Medigap insurance policies, and there's A, B, C, D, and keeping it all straight is impossible. I have a friend who was an advocate in the aging world. She called me up one day, literally in tears. She was about to turn 65, and she created a spreadsheet for herself, and she was completely lost. She had no idea what to do. And a lot of the decisions you make are effectively irrevocable. If you decide, for example, you're going to go into a Medicare Advantage plan, and you decide you don't like the care you're getting, you want to go back to traditional Medicare, you often can't because Medicare supplemental insurance will underwrite it. And so you've got to make the right decision. But if you make mistakes, you're in trouble. If you delay enrolling, you have to pay a penalty for every month you delay. So there is a program called SHIP. The acronym is very strange. A state health insurance program, which has nothing to do with states. It's really all about Medicare. Where there's a phone number you can call, programs you can go to, where you can learn about how to avoid traps and how to best get the best Medicare benefits you can. JCA is the program that runs, organization that runs SHIP in this area. Uh, it's a very important resource. And I talked to so many people who are lost and make mistakes with Medicare. It's a great opportunity to get it right. Just need to call.
Very much. In addition to the federal programs you mentioned, being affected, you've noted that there will be state and local impacts of these policy changes as well. For example, the federal employee layoffs will likely reduce revenue available for local government budgets. Can you speak to what we might expect at the state and local levels from these changes to the federal?
Sure. So an organization like JCA and other community-based organizations in this area rely a lot. Some of that money starts with the federal government, and it goes through the states and the county. Some of it is just state or county. Maryland is in real trouble. Montgomery County is in real trouble. When you think about the federal levels, there are, depending on who's counting, somewhere between 50 and 60,000 federal employees in Montgomery County. There's something like 130,000 federal employees in Maryland, civilian federal employees in Maryland. Then there are the contractors and the grantees, all of them apply. Think about NIH down the road, what's going to happen there. If a substantial number of those people get laid off, the tax base in Montgomery County in Maryland is going to be in trouble. Maryland, as you probably know, is going into this budget year with a $3 billion budget deficit that it needs to close. This is going to make that deficit worse. The county has been struggling to maintain services kind of at current levels. Shane can talk a little bit about prognosis for the next year, but it's going to be a tough time. And even if the federal programs that I was talking about survive relatively intact, there's going to be a problem with those state and local programs because the county is just not going to have resources. It's going to have to make some very difficult decisions, both the county and the state have to make some very difficult decisions. Do they raise taxes? Do they cut programs, or which programs do they? And unfortunately, when you look at the state and the county as well, this often comes down to a battle between schools and adults. Unfortunately, in that battle, we're adults. So I hope we'll be able to at least hold our own in the coming budget. It's going to be a challenge, and it's going to be a challenge for a few years left. This is not going to just go.
Before I go on, for folks in the room, I just want to mention that if you're listening to the conversation, you have a question you'd like to ask, you just put your hand up. Staff person will bring an index card to you to bring questions. Unfortunately, those of you who are online, we don't have a way for you to ask questions, but we will be addressing questions here in the room during the last 15 minutes of our conversations. So with that said, Howard, I wonder if you could talk a little bit about the impact on potential impact on area agencies and aging.
Sure. So the AAAs are programs that exist in every state, most counties around the country. They do a lot. Probably the most visible thing they do is they have an information flow solution called your area agency on aging to get information, services that are available. Each one of those programs is funded by the government. And it's a program that is at risk, no question. My view on area agencies on aging is that they are quite variable in the information, the services they provide. In some areas, they're actually very strong. In others, they're not so strong. Say something controversial, I think they could be stronger in my county. But they often are one of the few resources that's available to adults who are looking for information about where to get services. JCA has a senior helpline, which is another service I happen to think is better than the AAA, but that's just me. But it's hard to get that information. I'm sure those of you who have been caregivers have had this experience. You know, you get, let's say, a loved one gets a tough diagnosis. say a diagnosis of dementia. And now what do? No idea where to go to get the services that you need to help care for your mother. Where do they get transportation? Where can they go to an adult day program like we have at JC and Kensington? If they need meal delivery, how do they do that? Chances are the doctor who gave that diagnosis, whether it's a primary care doc or whether it's even a oncologist, has very little information about what's available to provide. Those social supports, those non-medical services are so important. When you think about a diagnosis like dementia, there's very little that medical treatment can do. We can have a debate if you want to about the drugs that have recently come online. But even those are for a very limited population. People with very early stage Alzheimer's don't help anybody else. But other than that, there's very little that the medical profession can do in terms of treatment to folks. But there's a lot that can happen to improve their lives with changes in lifestyle, with changes in exercise, diet, and so social supports. To use the example of JCA, we have the Kensington clubs for stage. They not only provide a great resource for caregivers because they provide that respite care, you can get a break and know that your loved one is being cared for 6 hours a day. And it's so important. But it's also really important for the participants because they're getting that kind of socialization. If you think about it, you live in a house in the suburbs, you've got dementia, there's nobody home during the day. Incredibly lonely. And being able to get together with people who are in the same situation you're in and having people who are professionals help you kind of manage what's happening. It's really, really important. Trouble is, two troubles. One of them is people don't know that adult day programs even exist. Talk to consumer groups, I say adult day, and they say, what are you talking about? What is that? And the other problem is it's not inexpensive. It's more or less $100 a day. That is not accessible to me. Medicaid pays for social adult day programs in some states, not in Maryland. So if you can't private pay, you need some other resource. You're fortunate, thanks to a county program, one of our adult day programs is free. But we're not on that way. So these are the kinds of services, the kinds of programs that are really critical. And one of the very important functions that area agencies on aging provide is they connect you, they link you with those services. How do I find an adult day program? Well, here's the phone number. Here's how you call Kennedy. That's critical. And if we lose that, it's really going to take a lifeline away from a lot of us and their families.
You mentioned healthy living, healthy choices a little bit in the comments just there. That made me think a little bit about at least the some of the ideas that Mr. Kennedy has talked about. However, go ahead.
Yeah, so Kennedy's the right word, an interesting guy.
Mhm.
So he says he wants to refocus the Department of Health and Human Services on chronic illness. Now, I have no argument with wanting to increase the focus on chronic diseases. I think it's very important. But now, how do you do that? Well, you do research on chronic conditions. Except he's going about slashing the NIH research budget. So how does that help with chronic conditions? How do we get it? Programs like the Older Americans Act, the work that the Administration for Community Living does, by definition, if you're eligible for those programs, you have a chronic condition. You have some disability. You have some chronic condition in old age. How does cutting those programs improve the quality of life for people with chronic conditions? He seems to think the only way he wants to approach this is by preventing these diseases. Now, there are some of them, for example, diabetes, where we know there's a lot we can actually do to reduce the amount of diabetes, which is way too much. We can change lifestyle, we can change that. He's not wrong about that. When he talks about, food that's available, a lot of it's really bad, and we can do something about that. But there are a lot of chronic conditions, arthritis, dementia again. We don't know really what causes it, or how to prevent it. So it seems to me that what you want to do is you want to provide services to people who have those conditions and help them manage them, even when you don't prevent them. And that's what Americans out, ECL, are supposed to do. To lessen. So I have a lot of trouble kind of getting what he's.
So that raises a question for me. Is there anything thinking about the totality of what's happened since January 20th that's positive for all of us?
So let me talk about it. So in terms of policy, there's one tiny little thing, which was that during the campaign, candidate Trump talked about creating a caregiver tax credit. Now he did this when Kamala Harris proposed a very expansive program to increase home and community-based care. And I guess they felt that they needed to come back with something, so they said, well, we're gonna have a tax credit, caregivers. They never said who would be eligible, they never said how big it would be, they never said when it was gonna happen. Since he's been president, I don't think that Trump has mentioned it one time. He talks about tax-free tips, he talks about tax-free social security benefits, he talks about tax-free overtime, or knows he talks about tariffs. But I have not heard him say anything about the caregiver tax credit. Now, there are people in Congress, there are bipartisan bills in Congress that would create this credit. You probably all know that at the end of this year, there's going to be a giant tax, multi-trillion-dollar tax. It is possible that somebody in Congress will slip with something like a tax credit into that bill, because it's be a tiny little thing. So that may happen, they get it. But how meaningful it's going to be, I don't know. Not to get too geeky about it, but one of the problems with tax credits is, well, they divide them up into two kinds, what they call refundable tax credits and non-refundable. If it's a refundable tax credit, it means that if you're low income, if you're make so little income that you don't actually pay taxes, a refundable tax credit means you'd actually get a check from the government for that amount. Say it's a $500 credit. But if it's a non-refundable credit, which this is almost certainly going to be, and you're not paying taxes, you don't get the credit. So who benefits from the credit? Rich people. Does it really make any sense to provide a tax credit to people who need it, when you could design policies that would focus the help on people who need it?
So there was an intersection between taxes and
There always is.
Thank you.
Listen, how do you think, Shane, about the good news? And I'm reaching a little bit here, but I'm going to try this. I'm a strong believer that we need community solutions to aging issues. That we need to do more to help one another, to help our neighbors, to help those people who are in our faith communities, help people who are in our social organizations as they age, and help caregivers. So how do you do that? You can rely on the government, but that's probably not going to be in the cards for the next few years. The other thing you can do is you can rely on community, you can rely on one another. And this is kind of a motivator for groups to begin to think harder about how they're going to help the older adults in their community and the family caregivers. So I'll give you just an example, one little example. The synagogue I go to, which is the Faireth Israel DC, has a program called Lots of Helping Hands. And it's basically based on a free web-based calendar program. We have a woman in the congregation, not the rabbi, a woman in the congregation manages. And if we have a congregant who has a health problem, or maybe congregant had a baby, and they need some support, they need some extra help, we put it on the listserv. Say, can you help? Can you deliver a meal? Can you provide transportation to the doctor? Can you provide transportation to services? And people step in and they do it. We are fortunate enough that we actually have more volunteers than we need people. We have people who need help, which is in some ways a good place to be, in some places not, because you always want to have something for volunteers to do. But it's really important and it really helps. Many of you probably know about the senior villages in the Washington metropolitan area. More senior villages here than probably anywhere in the country. They're also community-based not-for-profits. They may have an executive director, a small full-time staff. They may be entirely volunteer-based. And it's the same thing. What they do is they connect people in their community. Other people provide help. They can provide rides. They can provide friendly visits. They can provide advice for where do I get a good caregiver, or where do I get a good plumber. Those kinds of community-based, hyper-local community-based supports are going to be really, really important over the next few years. And this is a real incentive for communities to say, if we don't do it, nobody will. It's now a matter, I think, of the communities to find ways to learn how to do this. The other very important players in this are going to be the community-based organizations like JC that do have the expertise. And it's kind of the same story. People are going to have to learn. We have to do better marketing. People are going to have to learn that this is someplace they can go where they can get help. And then we need to be in a position where we can actually provide it. And that may mean refocusing a little bit on what community-based organizations do. But it's got potential. Now, clearly people get to a point as their impairments grow where help from their neighbors isn't going to be enough. Again, I'll take dementia as an example. If you're in early stages of dementia, that kind of help is really important. If you're in late stage dementia, probably not. You're going to need more care. And you may need facility-based care, you may need a full-time aide, you're going to need more than the community. But it's not a black and white story. If this community support works, you can delay for sometimes years time before somebody needs to go into a facility. That's a huge benefit, tremendous benefit. So, yeah, I think there's a lot that communities can do, and I think weirdly, this may be an important incentive for communities.
Thank you. Howard, I'd like to turn to something that's, I know near and dear to your heart, family caregivers. Can you talk about the impact of proposed changes to Medicaid or implementing family caregivers?
Sure. So, first of all, we can't agree on who family caregivers are exactly. But there are, depending on who you ask, somewhere between 20 and 50 million of them in the country, providing significant amounts of care to older adults who are young. They may be adult children, they may be spouses, they may be children, they may be neighbors, they may be friends. I even hear stories about former spouses who are helping their exes along. So they could be anybody. Having done it myself, and many of you have probably been caregivers yourself, it's really hard. It's really time consuming, it's exhausting, it's a financial burden on people. So now you think about family caregivers who can't work because their caregiving is taking up so much of their time, so much of their energy. Again, it's hard to get data, but the estimates, depending on who you ask, somewhere between maybe 12 and 20% family caregivers have to quit their jobs because of the caregiver. Many of them are low income themselves. So with that buildup, Shane asked about Medicaid. So Trump administration and Congress are talking about a number of fundamental changes. Two of them, which are kind of related, block grant the program, or sometimes they call it capita cap. What does that mean? So right now, the federal government pays for about 70% of Medicaid. States pay for about 30%. Varies from state to state, but that's sort of the average. That 70% share that the federal government pays, it pays 70% of Medicaid costs, whatever they are. So if they go up 10%, the federal contribution goes up to match that share. If you turn Medicaid into a block grant or capita cap, as they say, what would happen is the federal government would only pay a fixed amount of those Medicaid dollars. If the cost goes up, the federal government essentially be saying to the states, we'll pay a little bit of it, but you're going to have to pay the rest. You're on your own. And many states don't have the. If that happens, it's going to mean profound draconian cuts in the Medicaid. For older adults, what that's going to mean is, and states provide Medicaid long-term services supports for long-term care to older adults and people with disabilities. They do it in two ways. They're required by federal law to provide that care reimbursement. They must do it. They are allowed to provide care to people at home. But they don't have to. If that program is cut at those levels, what could very well happen is those home and community-based services will go away because the states are going to have to focus on the care must provide that law. Now, a less draconian change, but still a profound one, is this idea of a work requirement. So when Trump was president the first time, he said to states, you are allowed to impose a work requirement on your Medicaid. Have to, which you're allowed to. My fear is this time he's going to say, you must impose. And you're probably saying to yourself, what's a work requirement have to do with Medicaid long-term care? That somebody who's 85 years old, they require a high level of care now. And the law is going to exempt them from work. The question is, will it also exempt family caregivers? Those people I was talking about, those low-income people on Medicaid themselves, who are trying to take care of mom. And now the state comes to them and says, if you want to stay on Medicaid, you're going to have to get a job. And they say, who's going to take care of mom if I get a job? The state says, I don't care, not my problem. So there are some states that did a work requirement that have exempted family care. Discussed the idea of requirements of exempting family caregivers. There are other states, Arkansas, the most extreme example, it did a very tough work requirement, and there was no exception for family. It was a mess. What will the federal government do if it imposes a work requirement? I don't know. And it gets complicated. So if you're going to exempt the family caregiver, so who's the family caregiver? Let's say you have two siblings who are caring for a mom, both doing roughly the same amount. Which of them gets to be the family caregiver? Doesn't have to go to work. And which of them isn't the family caregiver? Does have to go to work. No idea how it's going to go. So I'll give you a prediction. My prediction is that the big giant cuts in Medicaid, per capita caps, the block grants, are not going to happen. I think that the Trump administration is getting an enormous amount of pushback from senators, some members of Congress, from governors, including red state governors, who know how important this program is to them. I don't think they're going to like that. But I do think a work requirement. And that potentially can have a profound effect on family caregivers and their ability to do what they do. I'm terrified at the prospect of somebody who has quit their job to take care of mom, who's exhausted, or doesn't have the resources to go out and hire paid aides, or the resources to come to JCA for $100 a day. And now the state says to them, you gotta go to work or you're gonna lose your income. It's a horrifying thought, but it's something that could very well.
That's a very, very dire thing. I'm wondering if maybe we can shift to a little more optimism. On here, I'm gonna ask you about this. So here at JCA, our programs have experienced a dramatic increase in demand for services this year. For example, last month, our 50+ Montgomery County Employment Expo had double the number of participants from the previous month. Our previous expo. You know JCA intimately. What do you see as the threats and opportunities for JCA and similar organizations in this environment?
So the threat, as I said, is the revenues. That those government grants and contracts are going to shrink. And it's a very real threat. Again, particularly because of where we are, because we get both policy reductions, cuts in federal programs, and we get terrible fallout of these cuts in federal employees, contractors, all the rest of the things. So it's a dual threat here. And I think at JCA, we need to either find ways to increase philanthropy, get more people in the community willing to donate and help us, or we're going to have to cut programs. I think it's going to be that simple. The opportunity is a little bit what I was saying. The need is going to be greater than ever. Shane, you mentioned CSEP, the job training program. So I wonder how many people who are participating in that job training program or in the training programs that we have for middle managers. How many of them are former federal employees? I think there's going to be a trickle more contractors. I think there's going to be tremendous growth in demand for that. I think another place where there's going to be a real need is going to be in this information. Yeah. People are going to need more assistance navigating this very complicated system. I think that's another place. Senior transportation, another thing. When I was going through the threats, I didn't mention, I don't know why I forgot, but I did mention immigration, which is going to be an enormous threat to families, family caregivers, who rely on aides to support them. This is going to be true whether you're living at home, whether you're living in a facility. But they also are going to struggle to get enough aides. So there's nothing that JCA can do about the immigration laws. Like that. But again, think about sort of the cascading effects. So you have somebody who's staying at home, and the only reason that they're staying at home is because there's an aide who could provide 4 hours a day or 8 hours a day to relieve some of the burden of your children or spouse. With the restrictions on immigration, there are going to be fewer aides available. The cost is going to grow. Around here right now, it's $35 to $40 an hour. In that environment, programs like Kensington Clubs become more important. Maybe I did the math before and I said, you know what, given my limited resources, keeping mom at home is the only way. Now I do the math. I say, it's gonna cost me $40 an hour to get a home care. Many times you have to hire them for a minimum of four hours a day. It's $160. I can get 6 hours at Kensington for $100. So I think that creates a real opportunity for us to expand a program, make it more available, which is really a good thing for everybody. But Shane can tell you, setting up one of these programs is not easy. You need to have a place, you need to have a staff, you need to go through training, you need to do marketing, you need to have a minimum number of people to make it work, to make the numbers work. So how do you do that? Where do you get the seed money to start a program like that? It'll take off once it gets started, but it'll take a while. It may take a few months, it may take a year to get critical mass participants. But that's the kind of thing that's an enormous opportunity for organizations like JCA. But it takes that seed money, it takes that opportunity to get it started. Information referral is another one. You know, we've had that program for years. I volunteered on it 10 years ago. It's a great program. Same thing, you need to hire staff, train the staff, and then you need to market it so you get the calls. Huge opportunity, but we need to be prepared. We need to have the resources to take advantage of it.
That's exactly right. This is a little thinking about older adults and how they're thought about by this administration, but also just in society in general. And it seems to me there's a lot of bias in the older adults in comic strips, on TV, and in interviewing for jobs, right? Do you have any thoughts on how we all online in this room can fight against these harmful stereotypes and biases?
Yeah, so ageism is a real problem. And it's one of those things that people don't even think about, they just do it. You know, if I see one more movie about cute old people escaping from the nursing home, I spit. That's how we do movies, old adults. Policy people, I'm going to exaggerate this a little bit, but not much. When I talk to policy people, old adults, they think of them as what economists would call a deadweight loss. They serve no use to society. So I talked before about this battle between schools and old adults. Talk to politicians on any level, and they're likely to say, well, we want to support the kids because they're our future. You know, want to get good school and want to get training, get educated, and all that stuff, because they're going to be the economy. And they talk about older adults, and they say, you know, they're going to die anyway. So, you know, and changing that mindset, I think, is really important. There are groups out there that do what they call reframing aging, and change the way people talk about it. And I think it's really important thing to do to somebody who's aging, right? But it really matters when you think about older adults in different ways. So one of the things that's very important, and this is something that comes up in villages, comes up again in faith communities. If you think about older adults as people who only take, they're only recipients of care. You know, they're frail and they can't really do anything useful, so we're just going to help them. You know, that's unhealthy for everyone. It's much healthier to think about older adults as people who actually provide services to their community themselves. I'll go back again to the experience of my synagogue. Many of the people who volunteer to help are themselves older adults. Many of the people who deliver meals to young families who just had a baby are older adults. You know, they can help. They're not just takers. Like, I'll tell you another story, another interesting example. I was talking to somebody who runs a senior living community outside of Boston. And she is trying to develop what they call a middle market. Community. So you don't have to have $1 million to buy into a community. You can do it with a reasonable rent. But to do that, they have to find ways to reduce costs, reduce operating costs. So one of the ideas that she came up with was, what if we had the residents volunteer to provide some of the services in the community? And what she discovered was, completely to her surprise, this was actually a marketing opportunity. People got in line to move into this community because they liked the idea of moving into a place where they could be useful. So some people might tell us that story and say, the community is just free riding on these people. They're just taking advantage of them. They're getting free labor. But the people who are moving into the community don't believe that at all. They believe, I'm 80, but I can still do stuff. So I think that the more that happens, the more we can break down this kind of ageism. Again, I'll talk about JCA. It's another classic example. We have a great program here called Intra-Agents, where older adults mentor young kids. It's great for the kids. And it's fabulous for the older adults because it gives them something important to do. And I suspect that the kids who are participating in this program, I don't know if anybody's ever asked them this, but I suspect that it changes their attitude about older adults. They're thinking a completely different way. And that's the sort of thing that has to happen. One last thing, I won't answer your question. You got me going. I spent a lot of time talking to doctors about caring for older adults. And that kind of ageism is rampant among physicians. Physicians' attitude, and they would never say it like this in public, but they believe it. You're going to die anyway. Nothing they can do. I hear so many stories. Somebody goes to the doctor, a primary care doctor. Doc says, "How are you doing, Mrs. Jones?" She said, "I'm feeling a little depressed." Doc says, "You're 85, your friends have all died, you should be. Don't worry." Hear that story over and over and over. We got to fix that. So I talk to residents, medical residents, and medical students about this. And they are trainable, they're educable about this. The 50-year-old and the 60-year-old docs, they're never going to change. But I think you can get to the younger docs, change that. But it requires work. It's got to be intentional. You can't just let it happen.
I think that was brilliantly said. I just want to add that from my perspective, one of the reasons I'm passionate about this organization is that we build on the strengths. We see the beauty in every older adult. Our staff here are dedicated to helping people live the best life they can. But we don't look at it like the doctors trying to solve the problem, right? So people aren't problems to be solved. They're people. So we're treating everyone in a person-centric way, as you see, in a way that really builds their strengths.
It's really important. Aging is not a problem.
It's not a problem. No, and it can be it is one of the great phases of life.
Sure.
And we're all aging, whether we're newborn or.
I mean, problems come with aging, but aging is not a problem in itself.
That's right. So I want to thank you and take some questions from the audience. Okay. Is Medicare and Medicaid, are they headed to privatization?
So Medicaid long-term supports and services, particularly, but really all Medicaid, is already privatized. That train left the station years ago. Almost all Medicaid is provided by managed care organizations, by insurance companies, some for not-for-profit, some for commercial insurance companies. States have essentially done, as they said to these insurance companies, we're going to give you a fixed amount of money per member per month. You do it. You're responsible. You do all the health care, you do all the long-term care, do it all. There's some potential benefit to that if it works correctly. And that benefit is, if I'm a managed care organization, the last thing I want is my member to end up in the hospital. Because if they do, it's going to come out of my pocket. They can stay home and be relatively healthy, they can make a profit. As soon as they land in the hospital, there goes my profit. So there's an incentive for both the managed care organizations and the members, the older adults, and actually other people on Medicaid as well, to stay healthy. That's the theory. Practice, it doesn't always work like that. In practice, one of the problems is that the managed care organization may say, we're not going to pay for you to go to the hospital even if you need to. So there are problems. But the short answer to the question is Medicaid is already privatized. Medicare, there's two kinds of Medicare. There's traditional Medicare, fee-for-service Medicare, which is the one that everybody's used to. You go to whatever doctor you want, you get Medicare supplemental insurance, pays for whatever it pays for. But then there's Medicare Advantage, which is Medicare Managed Care. I think the number now is 53% of Medicare enrollees participate in Medicare Advantage, already privatized. If there is no change in the law, the estimates are the Kaiser, formerly Kaiser Family Foundation, I don't remember, it's KFF, does analysis of this, and they estimate that in 20 years, 70% will be adults beyond. So again, it's already been largely privatized. Now, Trump administration. The Trump administration is kind of schizophrenic. So it's going to be interesting to see how this plays out. So you all remember this Project 2025. This was this conservative manifesto that was written campaign. Trump said he never do anything about it. It is the blueprint for his administration. In Project 2025, they said explicitly, we want to make Medicare Advantage the default option for Medicare. In other words, when you first become a Medicare enrollee, you will be enrolled in Medicare Advantage unless you explicitly say you don't want to. That would, behavioral economics tells us that would drive almost everybody in Medicare. At the same time, there are people associated with the administration who are much more interested in cutting costs, who have come to understand that Medicare Advantage actually costs more money, Medicare more money per patient, similar medical conditions than traditional Medicare is. And there are a lot of complicated reasons for that I'm not going to get into, but a lot of it has to do with plans' ability to change the way they code and pretend that their members are sicker than they are to get more money. So there are some people associated with the Trump administration who say, we're going to stop that. We're going to pay these guys an honest amount of money, but we're not going to overpay. The Justice Department actually sued and continued a lawsuit that was filed under the Biden administration against United Health for overcharging Medicare. So, question is, which is it going to be? Are they going to push more people into Medicare Advantage, or are they going to try to clean up Medicare? And if they do that, if they cut the federal payments to Medicare Advantage, you're going to see fewer plans in the program and probably more interest again in people getting. So I don't know how it's all going to work out. It's one of those things where you do for people.
Thinking of the federal layoffs, I think the private sector will benefit.
So the private sector is going to have a tremendous number of really, really smart, skilled people looking for jobs. That's good. Labor economics says you've got a lot of people competing for jobs. It's going to reduce the cost of the jobs. So I like that too. I think it's going to depend a lot, again, on what you do. So let me give you one example, which is one I've been thinking about a lot. So if you got 270, Germantown and Gaithersburg, all you see are these biotech companies, really interesting companies. Most of them are going to fail, some of them are going to do really great things. Those biotech companies are there because of NIH. A lot of them have cooperative agreements with NIH researchers. It is the whole basis of that economy. If those NIH grants go away, those biotech companies are going to go. Some of them will go out of business, some of them are physically going to move. So is the number of really good NIH researchers suddenly coming on the market good for those companies or bad for those companies? It's different for those companies. We'll just have to see how it plays out. The other, again, example of that are universities. The grants to universities are all read are getting slashed. $400 million to Columbia, billions of dollars to Harvard, a bunch of money to Johns Hopkins. Again, you're going to have lots of researchers who are going to be out in the wind. Also, we said a lot of those researchers are not Americans. A lot of those researchers are from India and China and Eastern Europe and all sorts of places. They're going to leave. They're going to go somewhere else. And they're going to do really important research somewhere else. So what does that mean for somebody who's in, say, the biotech industry here? It means that they're probably going to fall behind to somebody in Canada who suddenly got access to these brilliant minds. So the answer is, sorry.
I think we have time for one or two more questions. If we do run out of time, folks in the room, and you didn't get to your question, we will hang around a little bit after. Excuse me.
After I talk, everybody needs a drink.
It's just water. Will currently enrolled Medicare recipients be grandfathered in anticipated future changes?
So, changing the question a little bit first. And so you could also ask that question about Social Security. And I think the answer to that is if you're Social Security, if you're already a Social Security beneficiary, your benefits are probably not going to get cut until 2032 or 2033, whatever the year is, I can't keep track, when Social Security runs out of money. And when it becomes insolvent, the trust fund becomes insolvent, by law, unless they change the law, they're going to cut benefits across the board by 22%. Change the law, but they have to do it. So if you're getting Social Security, good for about another 9 years, 8-9 years. After that, oh, that's right. As far as Medicare is concerned, I don't see them forcing people who are already in traditional Medicare into managed care. I think they do. When I was talking about defaulting any new enrollees, people just turning 65, 60. I don't think they're going to force them. Where I think Medicare is going to get cut and where those cuts could affect people already on traditional Medicare. I think I said before, when Trump said, I'm not going to touch Medicare, what he meant was I'm not going to cut the benefits explicitly that Medicare participants get, Medicare get. But I think what he is going to do, what the Congress is going to do, is they're going to cut payments to providers. So think about already how hard it is to get an appointment with primary care. Like the primary care doctor is a great guy. I really like him. Yeah. I want to see him. I gotta wait unless it's something emergent. I gotta wait 4 months. There are more and more docs who are leaving the profession because they need the paperwork and they payment. Well, if Medicare reduces its payments to docs, you're going to have fewer docs getting Medicare. Already, you think about some specialties, behavioral health, psychiatrists. There's probably not a psychiatrist in the Washington area. They're all doing private pay because they can. They get more money, they don't have the aggravation. There are still other communities where there may be a few psychiatrists who are still doing it, cut their pay. So that's where you're going to start seeing limits to access. Another place where they do it is, or they may do it, is if you have a medical practice that's affiliated with a hospital, that medical practice gets more money for the same services than an independent medical practice. There's a lot of talk in what they call site neutral payment. Site neutral payment, bureaucratic jargon for we're going to pay the same amount to doctors who are affiliated with hospitals for doing the same thing as a community. That will also reduce the number of docs who will pay this work. Also, it's also going to change the economics of the hospitals in significant ways. Around here, we can probably live with that. If you're in a rural community, there's only one hospital, and you change the way Medicare is going to pay them, they could go out of business. A lot of them are teetering already, and this could be what pushes the edge. So, long answer to the question, yes, you could be affected by cuts. Absolutely. Not in the sort of obvious way that we get off, we get Medicare advantage. But clearly, these provider cuts are happening.
One last question. It's one I've been wondering too. I'm not sure you can answer, but I'm not. With all the hollowing out of the federal workforce programs and budget, it's trickle down effect on states and local government. Are we headed to a situation where everyone is on?
No, I don't think so. I mean, people will be less reliant on government, but not entirely unreliant. There still will be some Social Security. There still will be some Medicaid. There still will be some older Americans Act programs. Meals on Wheels is an immensely popular program. The first Trump administration, there was an effort to cut it, and Congress, even Republicans in Congress, rebelled. They did cut it. In fact, Trump actually raised the funding. So I think there are going to be some programs that will survive and will continue to support old adults. There will be others, some may get killed, others are going to cut back. But when you say on your own, I go back to what I was saying before. We don't have to be on our own. Communities, faith communities, villages, our neighbors can help us. And I think that's a real opportunity. So, no, I don't think, but it's going to be hard.
Sure.
Why is no thought being given to reducing the need for health care by banning tobacco, banning alcohol, banning guns? All of these things would significantly reduce the need for health care.
So people probably didn't hear that.
Yeah. So the question involved preventative measures such as banning tobacco, banning firearms, other things that affect health that are could be banned as an approach.
And junk food also, junk food, sodas.
So
Yeah, we don't need all that
to
stuff.
some small degree, you're channeling Robert F. Kennedy Jr., who wants to ban junk food.
He's not talking about banning tobacco. I even wrote to him about it.
So he is talking about changing incentives for junk food. I don't know if he's really going to do it. We'll see. Nobody in this administration is talking about banning guns. Nobody's talking about banning alcohol
And tobacco.
I suppose in perverse ways, Trump may not know it, but he is talking about banning alcohol because he's opposed a 200% tariff on wine, imported wine, which will also raise the price of domestic wine. So he's going to make it so prohibitively expensive, people may stop drinking. But no, this administration is not really into banning it. It's not really.
But that would significantly reduce all these costs.
Yeah, people can't do it. Talk about it all.
So we're at time. I want to thank our guest, Howard Gleckman, for being here tonight, for sharing his expertise, and for informing us. And so if we could just say thank you.